So, yeah, so this is the lipid metabolism part. The next one is, this is where the management, this is what we wanted to discuss today. So the general measures, the management of triglycerides always starts with general measures rather than specific drug therapy. The first one is addressing modifiable causes. And modifiable causes, all those patients who are taking, who are diabetic, or they are taking some sort of drugs which are called hypertriglyceridemia, or any other cause which is being implicated in hypertriglyceridemia, can stop the drug, control diabetes mellitus, or do whatever is the applicable part. That is the so that is the first thing we have to do, address the modifiable cause. That will be probably enough in at least a few of the cases to address hypertriglyceridemia. The next is non-pharmacological measures. I can hear my own voice. Can you please mute? Hello.
As a host, you have to mute everyone.
Yeah, so that is first part is addressing modifiable causes, and then instituting non-pharmacological measures. We'll talk about non-pharmacological measures. Yeah, this is non-pharmacological measures. The basic non-pharmacological measures includes optimizing the management of hypertension, smoking cessation, addressing a sedentary lifestyle. So in this, regular aerobic activity recommendation is strongly recommended. Either it can be moderate intense physical activity, about 150 minutes per week, which should be about 30 minutes per day. So 5 days a week is something that is definitely recommended. And then, or vigorous intense activity, about 75 minutes per week, or a combination of both. The next general non-pharmacological measure is weight loss of 5 to 10% body weight. So managing the hypertension, smoking, then regular aerobic activity and weight loss. These are the general measures which are recommended. So apart from the general measures, we do have specific recommendations for diet and alcohol under general measures itself. But that recommendation depends upon what is the degree of hypertriglyceridemia the patient is having. So that will vary, which we'll discuss in the coming slides. So the basic treatment goal of the hypertriglyceridemia is to reduce the risk of ASCVD, atherosclerotic cardiovascular disease risk, and reducing the risk of pancreatitis, reducing LDL cholesterol levels. So these are the basic treatment goals. So we start with modifiable, dealing with modifiable causes, and then non-pharmacological measures, and then we assessing ASCVD risk and optimizing LDL cholesterol management. The treatment before the triglycerides are addressed, we have to look at LDL cholesterol. If LDL cholesterol is actually the more important factor for ASCVD rather than triglycerides, so we have to address LDL cholesterol first, and then only take on the triglyceride part, because anyway statins, when you start with for LDL cholesterol treatment, most of them reduce triglycerides partly, at least by 20 to 30% decrease is definitely seen. Probably that could be enough in the long term. So after correcting LDL cholesterol only, even if then the triglyceride component is high, we can address that. Otherwise, LDL cholesterol component is the first one we have to address during the treatment. So these are the first few measures we have to take, address modifiable causes, non-pharmacological measures, and then start treatment for LDL cholesterol. So even in spite of that, if TG remains, triglycerides remain more than 150 milligrams per deciliter, then the specific measures will come into play. Here, as the algorithm is indicating, what is the severity? As we discussed yesterday, it's from moderate, severe, and very moderate to severe and severe. In moderate hypertriglyceridemia, which is about 150 to 499 milligrams per deciliter, Again, ASCVD risk is going to be the factor that is going to decide what we have to do next in all the three cases. So if the ASCVD risk is high, this we have a various trials that were done. Reduce trial is one of them. There are about 2 to 3 trials which were done to see effect of various drugs on triglycerides, especially omega-3 fatty acids. So of that, reduce IT is the one of the trials. So here the algorithm is talking about that trial, reduce IT criteria. So if the ASCVD risk is high, then we'll add omega-3 fatty acids. So marine omega-3 fatty acids. Then if it is yes, if the ASCVD risk is high, if it is no, then we'll continue with the general measures which we first discussed. Then next is moderate to severe hypertriglyceridemia, which is about 500 to 999 milligrams per deciliter. Again, the ASCVD risk comes into play here according to the reduced ID criteria. So if it is yes, then we again add marine omega-3 fatty acids. If TG is still high, then we add fibrate. So this is the next part they are mentioning in the same box. If in spite of using marine omega-3 fatty acids, if they continue to be high, you can use a fibrate. If the ASCVD risk is not high, then we can directly add fibrate. Again, if this is like a vice versa situation, if you add fibrate, if there is no response, if you haven't seen expected reduction, then you can go for marine omega-3 fatty acids. The last one is severe hypertriglyceridemia, where the triglyceride levels are more than 1000 milligrams per deciliter. So we have to continue the general measures. What they have given the explanation is generally drugs don't act when triglyceride levels are really high. Drugs don't act because VLDL rich TG particles are the ones which are the culprit for the hypertriglyceridemia, very severe hypertriglyceridemia. So drugs really don't act. That is what that explanation given. So drugs are not the first part which are given for severe hypertriglyceridemia. It is the dietary restriction. Usually dietary restriction actually helps in very strict dietary restriction, does help in lowering triglycerides in a very few days. It takes about 7 to 10 days or probably even less than 1 week. That definitely reduces. Once TG lowering is seen, then only we have to start the pharmacological treatment. Otherwise, starting pharmacological treatment will not be useful without a preliminary dietary intervention. So that was the algorithm. So these are the treatment goals, general measures, and modifiable causes, average LDL cholesterol. Then as I already told, in modifiable causes, we have glycemic control for patients with diabetes mellitus. Achieving excellent control is very important. In non-pharmacological measures, we have specific diet and alcohol recommendations. As I told, according to the severity of hypertriglyceridemia, the diet and alcohol recommendations vary in under non-pharmacological measures. So for moderate hypertriglyceridemia, the targets include less than 6% calories of added sugar, then less than 30 to 35% calories of total dietary fat, less than 2 drinks per day for males, and less than 1 drink per day for females. So these are the criteria to be applied for moderate hypertriglyceridemia. Whereas for moderate to severe hypertriglyceridemia, it is less than 5% calories of added sugar, less than 20 to 25% of calories of total dietary fat, and alcohol abstinence completely. For severe hypertriglyceridemia, it's complete abstinence of alcohol, and dietary fat is even more less. Dietary fat intake that is recommended. So this is where the management will vary according to the severity of triglycerides. Yeah, as I told, in severe hypertriglyceridemia, the fat is less than 10 to 15%. Completely eliminate the sugars and abstain from alcohol. This is very important because the risk of pancreatitis is very high in these patients. And for outpatients with severe hypertriglyceridemia, drug therapy for triglyceride lowering is generally deferred. As I told, it's the first LDL cholesterol that is to be addressed. Given the rapid rate of triglyceride lowering achievable with stringent dietary fat restriction, with close monitoring, it is possible to initiate drug therapy for hypertriglyceridemia within a few days. So a preliminary dietary restriction is definitely essential before you start any drug therapy, because the drugs won't act in whenever the levels are more than 1000 milligrams per deciliter. However, for inpatients, as I told, severe hypertriglyceridemia patients are very high risk of pancreatitis. So they are already with pancreatitis and who are in inpatients, you have to deal them with, start them on a fibrate. That is a very important component for them. Then, marine omega-3 fatty acids is actually being mentioned as a very important part of the treatment, and the choice will depend upon the level of ASCVD risk. For patients with high ASCVD risk, we prefer prescription strength of IPA, which is icosapentaenoic acid, EPA. This is the trade name of the general drug that is available right now. In patients without high ASCVD risk, any prescription high-dose marine omega fatty acid can be used. So with those with high ASCVD risk, we have to start definitely an omega-3 fatty acid. And for omega-3 fatty acids, as I told, you have two choices. Either it is ethyl esters or icosapentaenoic acid, ethyl ester. Then when choosing fibrate therapy, we generally prefer fenofibrate to gemfibrozil, since it has fewer drug interactions and is better tolerated, and the compliance is better because of once daily dosage. So when we are talking about fibrates, so we have to talk about all the hyperlipidemic drugs. In this, we have bile acid sequestrants like cholesterol, colsibulum, and which are right now being used. And so these drugs have only effect on LDL cholesterol. They reduce LDL cholesterol by 15 to 30% with no effect on HDL as well as triglycerides. So bile acid sequence are not at all useful in hypertriglyceride patients. The next is ezetimibe. Ezetimibe reduces LDL cholesterol by 17%, increases HDL by 1%, and reduces serum triglycerides by 7 to 8%. The maximum effect, as you can see from this table, is by fenofibrate, especially the micronized form, which is reducing serum triglycerides by 41 to 53%, as well as LDL cholesterol by 6 to 20, and raising simultaneously HDL cholesterol by 5 to 20%. So this is the maximum effect we are seeing. And then gemfibrozil is also reducing serum triglycerides by about 35 to 50%, but because of in combination with statins, fenofibrate is actually considered more superior because gemfibrozil causes more side effects. The myotoxicity that is in association comes up with gemfibrozil combination is more severe than in combination with fenofibrate because of change in metabolism of the excretion of the statins in the kidney. The next is nicotinic acid, which causes reduction of serum triglycerides by 25 to 30% and LDL cholesterol by 10 to 25. So this nicotinic acid can be given if you want a good increase in HDL cholesterol for the patients, especially 15 to 35% increase in HDL cholesterol is present with this. And then marine omega-3 fatty acids doesn't seem to have any effect on LDL cholesterol itself. As I told, this is more specifically given for triglyceride hypertriglyceridemia patients after starting all the dealing with modifiable causes, non-pharmacological measures, and dealing with LDL cholesterol. Then only marine omega-3 fatty acids is coming into it, because it doesn't have any effect on LDL cholesterol levels. It reduces serum triglycerides by 23 to 45%. Then we have the PC pro-protein convertin serum subtilsin kinase kensin 9 inhibitors, which are reducing LDL cholesterol more rather than serum triglycerides. Then statins are anyway there, which are reducing serum triglycerides by 10 to 33%, LDL cholesterol by 20 to 60%. Therefore, we're starting with statins for dealing with LDL cholesterol first. Then is the bempedoic acid, which is more effective on LDL cholesterol. So that was a comparison between various lipid-lowering agents. So among all of this, we can see fenofibrate is the best one. Next is monitoring therapy. After starting therapy, we should be knowing how frequently we should be measuring and when we should stop or taper the treatment. So the frequency of TG level monitoring depends upon, again, the severity of hypertriglyceridemia. As I told, for the severe hypertriglyceridemia patient, we will start with the dietary restriction and then only shift to the pharmacological therapy. So for severe hypertriglyceridemia patients, it is being recommended to measure the every third day or fourth day to see if there is any good improvement in triglyceride reduction or not, and then so that we can start the TG lowering drugs. For patients with moderate or moderate to severe hypertriglyceridemia, which you can check TG levels every 6 to 8 weeks after starting or altering the drug therapy. So that is good enough. 6 to 8 weeks is a good enough period to see if there is response to the therapy or not. Then pharmacological therapies and lifestyle modifications vary in how quickly and effectively they reduce the triglyceride levels. As we can see, we have to monitor and then keep changing the medication according to the response that is coming up. With TG levels more than 500,000 milligrams per deciliter, the expected reduction in fasting triglyceride with less than 5% dietary fat is 25% per day. It should be at least 25% per day. That is so that is why every third day we are actually monitoring in the case of severe hypertriglyceridemia patient. Reduction in fasting triglyceride should be less than 5% dietary fat. Is 25% per day. The majority of TG reduction with menin omega-3 fatty acid therapy is, however, seen in 2 weeks. A response to fibrates is seen as early as 2 weeks into therapy, with the maximal effect in 6 to 8 weeks. And niacin will take about 2 weeks for the therapy to come up. So this is where this topic ends.